Hey, just in case you didn't notice, I'm Clarence Wigfall.
I'm Cleopatra Tellis.
Danielle Blazek.
And today we will be presenting to you all about cultural competence and perceived responsiveness of healthcare providers.
In case you didn't notice, this week is going to be a little bit different.
What are we going to talk about?
Cultural competence and perceived responsiveness of healthcare providers.
Okay, good. All right. So I understand you two have a little exercising to do?
Yes.
We do,
Okay,
yeah.
well.
Gotta shake off all the readings, from this week.
Good. All right, then why don't you go ahead and get ready for that, and then we'll go ahead and get into the rest of it.
Will do.
All right. You guys, sit back, relax, enjoy the show. Beautiful day, isn't it?
It's gorgeous. Southern California, it never rains.
Love it here.
Do you know that song? Tony, Tony, Tony? It never rains.
No, I don't.
It's a good song. You should check it out.
Look into that.
Yeah. So, have you ever heard about perceived partner responsiveness?
I'm so glad you asked. I actually just read a lot about that. Perceived partner responsiveness to the self is a really good way to organize and categorize the study of interpersonal relationships. In fact, Reese, Clark, and Holmes in the Chapter 12 handbook, maybe you've read it? They define this construct as a process by which individuals come to believe that their relationship partners should attend to and react supportively to their core defining features of themselves. And culture can be one of those defining features.
Really? That's interesting because I actually just read something about connecting culture to the idea of perceived partner responsiveness. So it can be cultural competence can be referred to as a type of perceived partner responsiveness or thought of as one. And as mentioned in Chapter 12 by Reese, Clark, and Holmes that you were just talking about, a provider's well-intentioned efforts at support may not meet the target's particular needs, resulting in miscarried support. So in other words, there's much room for subjective interpretation in process of receiving social support, allowing personality and other relational schemas to color constructs of responsiveness to needs. So with this being said, according to Reese, Clark, and Holmes in Chapter 12, successful responsiveness to the perceiver's needs and how they interpret interactions with others can be informed by recognizing the type of relationship that exists in the nature of the social environment.
It's really interesting. It's kind of a little bit like trust.
Yeah.
I mean, maybe a little bit of a stretch, but trust is also a really important concept that we should pay attention to. And I don't know if you've ever read, but Canavello and Crocker in 2010, they wrote that people usually don't trust someone who is not responsive to them. And perceptions of a partner's unresponsiveness or not responding to their core concepts may actually signal to someone that they should protect themselves and maybe interact less with someone who's not responsive to them. And in addition, authors Peets and Kamrath, they suggest that there can be a negative consequence of somebody who makes a promise but doesn't keep that promise. The partner may perceive the broken promise as a relational transgression. In other words, broken promises and breached trust can result in mistrust and cause a perceiver to protect themselves from the lack of responsiveness to their needs.
Wow, that's interesting because it makes me think of how that might interact with someone's goals for a relationship and their expectations. And going back to Reese, Clark, and Holmes, my favorites, they expressed in Chapter 12 that relationship goals, such as to secure a close communal or exchange relationship, is influenced by perceived responsiveness. And they also add that expectations and self-regulatory processes channel interaction in a manner that evokes behaviors by self and partner that confirm existing expectations.
That's really interesting, Cleo. I think we should definitely talk about this a little bit more.
We should, especially while we exercise. Perfect time.
6 decades ago, indifference and injustice combined to begin to write one of the most shameful chapters in the history of American medicine. Of course, the infamous project called the Tuskegee Study of Untreated Syphilis in the Negro Male. In 1932, America's Public Health Service set out to study syphilis, but it pursued this worthy goal in a manner that was irredeemably cruel. Several hundred African American men the Public Health Service recruited at churches and clinics and farms, were used in the study. Most of these men had syphilis. None of them knew their bodies harbored this disease. And then the Public Health Service followed the men's lives, watched how the disease developed, all the while withholding medicine, withholding treatment of any kind for these innocent American citizens. Medical professionals willingly, intentionally let human beings suffer from a treatable and then later a curable illness.
Well, you might wonder how this all fits with this idea of trust. So we started with the Tuskegee study because when you look at an ethics timeline presented by the National Institutes of Health of research ethics, it starts with that particular study, 1932 to 1942, 40 years of studying people who are infected, and you know they're infected, and there's treatment, and you won't give it to them. Then, of course, as we go down, we see that German scientists in 1939 through 1945 were conducting research on concentration camp prisoners. And then we have the two refugee scientists, Frisch and Perls, who warned the United States about Germany's nuclear weapons program. Then we start the Manhattan Project right in the United States. And 1944 through the 1980s, the United States sponsors secret research on the effects of radiation on human beings. Then we looked at 1945, and this is from the NIH list, not just what we're making up. The United States drops 2 atomic bombs on Japan. And then 1947, finally we get to the Nuremberg Code for research on human subjects. It's adopted. The Allies used the document in the Nuremberg trials to convict the Nazi scientists who were conducting these experiments on prisoners, and they're found guilty of war crimes. Then we have 1951, and this isn't really included in the NIH timeline, but the information on lax and the HeLa cells that were taken from her. She didn't know it. She died. She didn't die because of that, but her family didn't know until years later they discovered that there's a huge industry been built around the use of her cells. And then as we continue on down from that immortal HeLa cell line, 1956 through 1980, we have researchers who conduct hepatitis experiments on mentally disabled children. 1950s through about 1963, the CIA begins a mind control research program, and they begin administering LSD to unwitting subjects. So we see there's a long history, but we're going to discuss in more depth things that happened as a result of the Tuskegee experiments. But then we might even think of our own field. Remember Stanley Milgram and his electric shocks. So it gives us things to think about, that ordinary people might actually become involved in these kinds of things. And then finally we have the Helsinki Declaration in 1964, which provides ethical principles for research on human subjects. But here's the question. With this long history of experimentation and work that today we would consider to be questionable, unethical, is there any surprise that there might be cultural groups who really have a serious lack of trust in areas of medical and health care? So we'll continue and talk about that a little later.
I'm working up a sweat, man.
Yeah, I feel great. I feel the burn.
A slow burn.
Hey, you know what I was thinking?
What were you thinking?
I read an article the other day about cultural competence of healthcare providers and how that influences how patients adhere to medical orders. And I was thinking that's a really narrow perspective, but it's also very important. So I'm wondering, do you know of any, broader perspective out there, like a broader viewpoint on cultural competence, not necessarily looking at a particular group, but just in general?
You know, I just read something just like that. Reese and colleagues, I think there were 6 of them,
Okay.
2008, they did a study where they were trying to design a measure of perceived responsiveness to physicians from a patient perspective, and it really does have a nice broad perspective on this issue and gives you kind of a general overview of what the topic's about and why it's important. I'd be happy to send it to you if you'd like to read it.
Oh, very cool. Well, I actually want to hear you tell me about it because I want to tell you about the narrow perspective that I found. I'm sure there are some intersections between the narrow perspective and the broad perspective, and also maybe the historical accounts that Clarence covered earlier. So, yeah, let's talk about that. But I would like to hear about your article first.
Definitely. Let's take a seat and we'll talk about that. So Cleo, I read an article by Reese and 6 colleagues discussing patient perceptions of physician responsiveness. And within this context, physician responsiveness is meant to capture how well the patient thinks the doctor is doing, understanding patient concerns, and providing both appropriate and sufficient care. Now I know what you're thinking. How is this different from general satisfaction, and why does it need to be measured separately? So general satisfaction actually deals with a global assessment or judgment of care, but it's doing very little to provide insight into the actual patient-physician relationship. And a sick patient might just be more likely than, say, a healthy patient to be unsatisfied with the care that they're receiving. Another example is somebody who comes to the doctor with a low expectation of care instead of a high expectation of care due to prior experience may simply evaluate the same care that they receive differently. So a measure of patients' perceived responsiveness has a behavioral component, and it's one that allows a potential intervention. So for example, if a patient wants to be listened to, doctors can practice listening to their patients when they hear feedback that say patients need to feel that you're listening. Why does all of this matter? So intimacy and trust develop when one feels understood, validated, and cared for. And we need people to trust their doctors in order to allow doctors to provide the best care that they possibly can to their patients. For patients to feel that their doctors are responsive, a doctor must understand a patient's health concerns, they must accept those needs as valid, and finally they have to provide an appropriate care and support for those needs. The relationship between perceived responsiveness and trust is undeniable. And in this case, the perceived responsiveness and trust relationship is one that functions very much like that between members of a romantic partnership. So this particular study by Reese and colleagues was designed to create a measure of patient perceived responsiveness of their physicians. And they had 3 primary hypotheses with this study. First, that physician responsiveness would relate positively to patient satisfaction. Second, that it would relate negatively to patients' subjective health concerns. And finally, that it would predict subjective patient health status over and above patient satisfaction. So Reese and colleagues collected 3 patient samples, and they collected a sample from the United States, from the UK, and from Canada. And they did this because they were interested in having a diverse set of cultures utilized. And while you may not think this is a particularly diverse set of cultures, it does allow Reese and colleagues to have a little bit more flexibility in terms of saying this doesn't work in just one place at one time. So they collected a sample of 300 participants from the United States, 200 from Canada, and 319 from the United Kingdom. And participants completed 79 questions, and these questions assessed things regarding their perception of physician responsiveness, patient satisfaction, and subjective health assessment, as well as demographic issues. Participants were asked to identify the doctor that they felt they had been in a consistent relationship with, so somebody that they had seen before in the past, somebody that they plan to see again. In other words, their primary routine healthcare provider. So what did they find? They found that their three hypotheses were supported. First, perception of responsiveness predicted both patient satisfaction and subjective health status. But more importantly, even when general satisfaction was controlled for, perceived responsiveness was still accounting for a substantial portion of subjective health problems, suggesting that when patients feel that their physicians are responsive to them, they're actually reporting having better outcomes and feeling healthier and happier. And this harkens back to Baumeister and Leary and the belongingness hypothesis, which reported evidence that when people have significant relationships with others, they have better health outcomes. They also found that patients who had been with their current physician for a longer period of time actually expressed more perceived responsiveness towards their physician. So, what does all of this mean? Nothing. It means nothing.
Sorry.
So all of this is really interesting, but there are a few limitations in this study. So for example, only the patient perception was taken into account. No evaluation from the physicians was taken. Perhaps some of these patients were particularly troublesome. Additionally, all of the reports are subjective, so health outcomes were measured in subjective health outcomes, not necessarily that the patients were actually healthier, but simply that they reported being healthier or feeling healthier. And finally, all of the participants in this study had to have a doctor that they considered their routine healthcare provider, and perhaps people who have a routine healthcare provider are more likely to observe responsiveness from their physicians. For in fact, if they did not have that sense of responsiveness from their doctors, they'd be unlikely to go back to these people for future healthcare concerns. So Cleo, that is essentially the broad idea of what patient perceived physician responsiveness is all about. I'd love to hear more about a slightly narrower perspective.
That was so much great information. I am so excited to talk to you about the narrower perspective of the study that I looked at and how the two intersect. So what Gaston studied in 2013, she investigated the relationship between African American patients' perceptions of the cultural competence of their HIV healthcare providers and the adherence of these patients to medical self-care and antiretroviral therapy, or ART. So a couple things motivated Gaston in looking at this phenomenon. And one of those things was that at some point in their lifetimes, 1 in 6 African American men and 1 in 32 African American women will be diagnosed with HIV. In addition to high HIV rates, disparities exist in this population's retention of medical care that fosters dismal long-term health outcomes. Something that we talked about a little bit earlier with responsiveness was trust. So cultural competence being viewed as responsiveness helps us to understand how medical mistrust exists in this population with the healthcare system and how that's relevant to how responsiveness from healthcare providers can influence how the African American community perceives their competence. So, one thing that Gaston talked about in her article was that medical mistrust may partially attribute to disparities in treatment and health outcomes, and mistrust of health promotion may be attributed to negative perceptions stemming from unethical research practices experienced by African Americans. And as Clarence talked about earlier in his segment, is that throughout history, we see that there have been some negative experiences between several cultures and the health care system in America. Also, conspiracy beliefs arise from perceived discrimination and range from the conviction that HIV/AIDS is a man-made weapon of racial warfare among the African American community, and that was seen in a study done in 2011 with Bogart, Galvin, Wagner, and Klein with a sample with 181 HIV positive African Americans. So as far as this study is concerned, this sample consisted of 202 African American patients who were eligible with 5 criteria. So the first criteria is that they had to self-identify as African American, they had to be at least 18 years of age, they had to be diagnosed with HIV/AIDS, and received primary medical services from the Core Clinic in Chicago, Illinois, which is where they were recruited, and also they had to be prescribed ART, which is antiretroviral therapy, by a healthcare provider. Now, these participants consented by responding to an information sheet with explicit instructions, and they completed their survey anonymously. They were recruited in the waiting room of the Core Center Clinic in Chicago, and there were recruitment scripts that peer investigators used to recruit them. Sorry, I know I jumped around. So this study used a cross-sectional exploratory descriptive design to examine the relationship between African Americans' perceptions of HIV/AIDS, care providers' cultural competence, and the adherence of these individuals to medical, self-care, and art. So among the scales that were used was a survey called the Patient Assessments of Cultural Competence Survey, or PAC. And that survey included 4 subscales that examined the role of culture in HIV/AIDS, the patient's trust of their healthcare providers, the patient's understanding of the quality of communication that their healthcare providers possessed, and the shared treatment of decision makers between the patients and their healthcare providers. In addition, the medical self-care that the patients engaged in was measured using the Advice and Instruction Scale, which was developed by Holzemeyer et al. In 1999. The patient medical self-care was measured by the Self-Care Symptom Management for People Living with HIV/AIDS survey instrument developed by Kimpanin et al. In 2003, and ART adherence was measured with questions from 2 of the survey instruments from the Adult AIDS Clinic Trials Group and the Adherence Barriers Self-Report and Adherence Self-Report instruments. So they found a lot of really interesting and important things from administering these surveys to their sample, but I want to talk about some of the key findings that help us to see how trust, cultural competence being understood as responsiveness, and even schemas that was developed from experiences throughout history that African Americans have had with the healthcare system, and how they look at the competence of their healthcare providers and how that influences what they engage in as far as like healthcare and well-being. So that kind of takes us back to another week where we talked about schemas. So some of the key findings include the more patients believe that their healthcare providers should integrate their culture in HIV treatment, the more adherent they follow their provider's advice and instructions, and the better their reported health. There was a significant relationship between provider trust, medical self-care, and some covariates. And the more patients trusted their providers, so that trust theme comes up again. And Danielle, I saw that trust theme come up in your article as well, so there definitely is a relationship there. So the more patients trusted their providers, the more they were involved in self-care symptom management, the better they perceived quality of provider communication. So again, going back to that broader perspective article, the communication and being able to listen to your patients is important. The more adherent patients were to a provider's advice and instructions, and the better their reported overall health status. So again, that health status and how they perceive satisfaction and actually being well taken care of had to do with cultural competence or responsiveness in the case that we're looking at it. So why is this important? Why does this matter? I want to close this up with a quote that Stone offered in 2004, which is as follows. To optimize care, clinicians should incorporate a cultural competence framework, enhance patient-provider communication, diversify clinical staff, and be attentive to issues related to adherence to treatment. So Danielle, I hope that this helped you to gain a narrower perspective from your broader perspective, because I definitely gained a more broader perspective from the narrower perspective that I had.
So that's our discussion about cultural competence and perceived responsiveness of healthcare providers. And certainly that does fit with our subject as we look at perceived responsiveness, cultural competence, trust, goals and expectations, and the history of healthcare, health experimentation in the United States and in other places. So our discussion will help us to appreciate that we can look at these areas in far greater scope than just, let's say, romantic relationships. And although romantic relationships make an excellent area in which to do this particular kind of research, we can look for solutions to some of these other problems and apply the same principles, the same models, and the same theories. So we know you're going to have some questions about everything that we talked about, and of course we'll be really happy to discuss those. But we'd like you to think about how all of these elements fit when we think about healthcare. And there are other areas as well that we can talk about in our discussion where all of these areas apply to how we respond to the people around us, how we respond to the situations, how we respond to those who serve very important needs that we have. So we're looking forward to that, and thank you very much for your attention, and that's our presentation.
We hope you enjoyed the show.
Oh, and we hope you enjoyed the show.